Hello, welcome to PCR webinars today. I'm Ole de Bakker. I'm working in Copenhagen in Denmark. I'm joined by some great faculty here, and the topic of today will be revisiting aortic valve replacement in light of the new European guidelines for the management of patients with valvular heart disease. So what will be the learning objectives of today? Well, I hope that after this hour here that you have learned actually something about the key updates in the latest European guidelines for the management of valvular heart disease. Also that you understand why cardiac CT is now a cornerstone in the workup of patients with severe aortic stenosis, and that you also understand which factors matter when selecting the index valve. I have the honor, as I said, to have a great faculty here. We have Thomas Pilgrim from Bern in Switzerland, who's here locally with us, and also Alper Öner from Leverkusen in Germany, and Lenard Conradi will later join also online. Lenard is working in Cologne, in Köln University Hospital in Germany. So with no further ado, I think I'm Ole, as I said, and we're going to jump right away into this new document, yes, in the new guidelines, which we're going to discuss first a little bit before we're going to also show you some case. So this is a document that was released and published in summer 2025, as you all know, and a big part of this document was also spent to aortic stenosis. That's the topic of today. But before we go into that, I also want to still emphasize that a lot of weight has been given in this document to the value of heart valve clinics, heart valve centers, and also the multidisciplinary heart team. This is really a core function, and I think it is strongly recommended that every single patient presenting with valvular heart disease who should have an intervention is actually discussed at this multidisciplinary heart team. We will discuss this further also during this webinar, but this heart team should consist of a surgeon, an interventional cardiologist, and also somebody with imaging expertise. So we will come back on that further as said. So to put everything in context also, this is unchanged of course, but still it's nice to have a context. So for very young patients, first option therapy that we typically consider is the Ross procedure. That's kind of first recommendation. But then if we go to the more adult, in older age to up to 50 years, then of course you have to consider there the mechanical valves up to 60. And then from 60 years on or older, then typically we start to think of bioprosthetic valves, whether this is surgery or transcatheter therapy. That has to be discussed, and that's guided also by the new guidelines, of course. So the first entity is, of course, for indication, symptomatic aortic stenosis. We have also the asymptomatic, but first let's focus on symptomatic aortic stenosis. I think there are relatively few changes. We have, as you are familiar with, the class of recommendation. This can be 1, 2A, 2B, or 3. And then we have the level of evidence. Level of evidence is A is the highest. It's typically based on some really good multiple randomized trials. Level B is typically maybe only one randomized trial, but also some larger trials, but not really a lot of, no major randomized trials. And level of evidence C is actually there's no real strong evidence for, but it's more an expert opinion. So symptomatic aortic stenosis, I think there's no discussion as long as your patient has a symptomatic, severe aortic stenosis with a high gradient, meaning a mean gradient typically of more than 40 millimeters of mercury, it's recommended, strongly recommended to treat your patient. I think everybody agrees on that. That was also agreed already in the former guidelines. Also, the classical standard low flow, low gradient patients with a reduced ejection fraction, less than 50%. Also there, if it's a confirmed severe aortic stenosis on your echocardiographic parameters, this is class 1 recommendation to intervene on these patients. Then you have the class 2A, so that means it should be considered intervention. Well, this is the patients with the so-called paradoxical low flow, low gradient patients. That's patients where you measure a lower gradient, a mean gradient of typically between 25 and 40. There is a normal ejection fraction, a preserved ejection fraction, but there is a low flow. Typically, these are smaller ladies, in my experience, with a smaller LV cavity, and that's why they produce less cardiac output. So these should also be considered for intervention. So I think here, Thomas and Alper, I don't think there's a lot of novelty or updates in the new guidelines. But this is different in the asymptomatic patients. The asymptomatic patients with severe aortic stenosis, there are some updates. Before discussing this, based on these on this slide, maybe I want to hear how, because now there is a change, maybe Thomas first, do you see a whole new cohort of patients referred to you with asymptomatic severe aortic stenosis for TAVI treatment?
Well, I think till now, the majority of patients referred to our center are referred for symptomatic severe aortic stenosis. There are certainly some patients referred for asymptomatic aortic stenosis, but I would say oftentimes these patients are incidentally detected with severe aortic stenosis during the workup for non-cardiac surgery, for example.
Yeah. Alper, same for you?
Same in our center, and to be honest, I do not really believe in asymptomatic aortic stenosis.
Yeah, that's a often heard remark.
Opinion, yeah.
No, but it's a good point. Well, it's true that sometimes, especially if you're elderly patients with even a high grade, they're not reporting a lot of symptoms because they're very sedentary.
Absolutely.
They're not very mobile. They sit in their sofa almost the whole day. So that's a good point. On the other hand, if we go straight into the slide again and to the guidelines, well, the update in the guidelines is actually based on the early TAVR trial. And in the early TAVR trial, what they did is they put these patients on a treadmill. Yeah, so they kind of let them exercise, and these patients were detected as not reporting really tremendous symptoms. So there must be some patients out there. But you see now, this is actually the second recommendation you see on this slide. So intervention should be considered in asymptomatic patients these days with severe high-gradient aortic stenosis and a preserved ejection fraction as an alternative to close active surveillance if the procedural risk is low.
But Ole, not to interrupt you, but why should we wait for the first event?
That's a very good point. I think that's indeed, well, everybody knows where it historically comes from, that you know the curve there from the mortality, yes, that it goes steep down as soon as there are symptoms. But I do agree this is probably not the practice we want to do anymore, and that's why there's an update in the guidelines. Yeah. So I think, indeed, especially if you're very sure about your diagnosis, severe aortic stenosis, is the procedural risk considered low, I think probably the message is that you should kind of think of proceeding. Yes. And there, even if we go back to the guidelines, you see what we already knew is that if we had an asymptomatic patient with severe aortic stenosis and a reduced ejection fraction, yes, but without any other cause, so no ischemic heart disease, well, that was already a reason to intervene on that patient. That was already so in the former guidelines. What is also nice is that it's listed up there. You see on the third part. So if there is a really high gradient, of a mean gradient more than 60, or there is on CT, severe valve calcification, so CT there gets upgraded also, and it becomes important even in your diagnostics. Also increased pro-BNP, or a tendency of some systolic dysfunction, yeah, you really have to think of treating this patient. And I fully agree with you. You probably don't have to wait until the first symptom, because the first symptom could be a fatal one, or a very major syncope where patients break maybe their orbita or something else. So indeed, I fully agree. I think this is a great update, I think, and backed up by the evidence from the early TAVR trial. This is about indication, yes? Symptomatic, asymptomatic patients, small couple of updates. But then, of course, the mostly debated one change in the guidelines was, of course, the change of intervention for the cutoff age, yes? So it was 75 years in the European guidelines, above 75 to TAVI, below 75 to surgery. This is now in the updated guidelines from 2025. TAVI is now recommended for patients 70 years of age or older with tricuspid aortic stenosis if the anatomy is suitable, and surgery is recommended clearly with a class 1 recommendation for patients younger than 70 years of age if the surgical risk is low. And all the other patients have to be, it says, SAVR or TAVI. They have to be discussed at the heart team meeting. So that makes sense. We will come back later also if we have the evidence actually really to justify this change to 70 years. But an interesting one is the lowest one. So TAVI may be considered, it's only a 2B recommendation, may be considered for the treatment of severe bicuspid stenosis patients at increased surgical risk, and if the anatomy is also suitable for TAVI. So, Thomas, how is this going in your heart team discussions? Bicuspid patients, is there a clear something like it is always surgery or from a certain age, or some other aspects that play a role there?
No, I think there are no clear rules, so I think the heart team is very important in these patients. I think what's important that there's a relevant proportion of these patients with bicuspid anatomy that actually does have an increased risk for surgical aortic valve replacement. But in these patients, anatomical considerations come into play, and anatomy can really be a cocktail of risks in these patients with bicuspid anatomy. I think that, for example, patients with a long raphe, with a long calcified raphe, are certainly at increased risk for periprocedural complications, but we are just beginning to understand which factors really come into play and which factors are really important, not only for periprocedural success, but also for long-term effectiveness.
Yeah. Yes.
So as you know, Ole, we prepared some more webinars during this year, 2026. So therefore, maybe the bicuspid aortic valve stenosis is a topic for one of the
Yes, this
webinars.
is such an important topic.
Absolutely.
And indeed, this webinar is one of a series of 6 PCR webinars, all on the topic of aortic stenosis, which are all going to be really interesting. And I think one of the webinars indeed dedicated fully on bicuspid, because there's a lot to discuss, as you hear, like anatomy, treatment, sizing. So we keep this for a separate webinar. So this is a cliffhanger for a future PCR webinar. So going further, I think, again, I want to emphasize once again, also on the mode of intervention, it says the document that the heart team assessment is really key. You see there a class 1 recommendation for heart team. That means every single patient should be discussed at the heart team. I know it's level of evidence C, so that means there's no real evidence, of course, but it's a strong expert opinion. And I can even share a bit from experience also in Copenhagen. We made it already now 4 or 5 years ago mandatory that every single patient who's booked on the heart team meeting for discussion of severe aortic stenosis, they must have a cardiac CT. And if there's no cardiac CT, the patient will be removed from the heart team meeting, and we wait until he has the CT because having the heart team meeting discussion together with our surgeons and the interventional cardiologist and the imager, without having this imaging tool of the CT, is almost pointless, because you're just discussing an age and some comorbidities, but you're actually very interested in that anatomy too. So we are strong believers that heart team meeting assessment is important, even for, let's pass the really young patients, even the very old patients of 85. Of course, these patients are going to TAVI, but it's good to know each other's practice, that the surgeons hear from us how we reflect about the older patients, how surgeons think and what therapies they can offer in my center. Do they do annular enlargement, yes or no? When do they offer it? There's a lot to learn in these heart team meetings and assessments as well. So then you see this is also from the very nice figure from the new guidelines. You see there, this is summing up some aspects which favor either surgery or TAVI in our patients with severe aortic stenosis. You see on the top already, this is the new age cutoff, 70 years or younger. And then you see also some anatomical aspects, some concomitant comorbidities, frailty, etc. But I don't want to go in detail now at this particular moment on this. We will take this later into discussion. But now I think it's a good moment to make contact with Lenard. And Lenard, I think you have a nice case prepared for us, where you're going to show us what you did in a patient fitting into these new criteria of the new guidelines.
Thanks, Ole. I hope we can hear you guys can hear me. I followed your discussion closely. Very interesting, I think. And thanks again for PCR for hosting this. Yeah, so we thought when planning this to go, real world like as possible, so case based. And this is the case that I wanted to share with you guys. 71 years old, male patient. He was a classical aortic stenosis patient with classical symptoms. Of course, the first, here's his clinical profiles, just again highlighting that this is a low-risk patient. There's nothing really, limiting his life expectancy. A little overweight, yes, but very active and in good shape, I would say. This is the echo, and again, you will not be surprised that this describes a classical severe aortic stenosis with a 42 millimeter mercury gradient, with some cardiac damage in the sense of left ventricular hypertrophy, good LV function, good RV function, so nothing increasing risk or determining therapy beforehand here. And I can applaud absolutely what you guys have been discussing, not only for intervention. I'm trying to persuade my fellow surgeons, CT should be indispensable, not only for aortic stenosis, but on a side note, even for mitral patients, for aortic stenosis, there's so many things you can learn. But anyways, this is the CT of this particular case. Large anatomy, look at this, annulus close to 30, LVOT even a little larger, and then on the valve level, moderately calcified valve, tricuspid for sure. Here you see the values of the sinus of Valsalva, good coronary distances, as you should expect from this large anatomy, and no issues with access should we opt for intervention, I would say. And we always, this is a fixed algorithm. Of course, we run through the whole data set and predict angulations here, as most of you probably will do. So this is the case. There's nothing much more to say here. And then we thought to put up a poll here. So obviously, we have two therapeutic options, and I will read them to you before we show the poll result. On the left side, the classical approach, up to the wording or publication of the new guidelines, biological, surgical aortic valve replacements. You could say, pick a valve that has proven long-term durability, benefit the patient with low risk for conduction disturbance, which should be in the low single-digit range for surgery, or, as maybe the new guidelines are suggestive of, transfemoral TAVI, should be technically possible here. Superior peripheral safety profile. I think that's something that you could say, now with all the evidence that we have from the past few years. I think with this anatomy, at least that's my personal read from this case, anticipated adequate valve function and in a low anatomical complexity case. And let's see what the auditorium, what the people on the website have voted for.
Leonard? Okay, you show it. So he shows it. I wanted to otherwise ask, indeed, so now we can see, indeed, so Leonard, we see that, indeed, from the audience, 1/3 would, for this particular case, as a summary, 71-year-old male patient with hardly any comorbidities, tricuspid, but aortic stenosis, but a large anatomy, good access vessels. So 1/3 would opt for surgery, 2/3 would opt for TAVI.
To be honest, Ole, it would not be my expectation.
No.
It was not my expectation. It's quite surprising for me, I would say. The same for you, Thomas? Or?
Well, I think he is a good candidate for both treatment options. Yeah. And I think, you certainly can do transcatheter aortic valve implantation in such a patient, but you need to be sure that you can offer him an optimized treatment result. I think you need to have an anatomy with a minimal risk of residual paravalvular regurgitation. You need to achieve good hemodynamics. You need to have good valve expansion, maybe minimize the risk of permanent pacemaker implantation. But in a 71-year-old patient, it's also important to have the possibility for future interventions, because with the first valve, you only set the stage for subsequent intervention or potential subsequent interventions. And you need to have the possibility to do a repeat procedure in such a patient. I think that's really what this decision would come down.
But the same is for surgery, isn't it? So even if you do surgery, if you expect valve durability for 8 or 9 or 10 years, you have to expect that you do a second procedure. So it's about the procedure.
To make the patient also ready for re-intervention.
Yeah,
well, maybe if Lenard is still online, I hope so, maybe he could share with us, what was the rationale in your hospital then to, I think we can say that this patient was, of course, also offered TAVI treatment. What's the rationale you follow today in your hospital to offer this patient now TAVI?
Yeah, I mean, it's been a mix of things that you have just discussed, the three of you. All the things that the guidelines suggest to us, a good candidate for TAVI. I think you can clearly state that this case or this patient is a good candidate for TAVI from the access to the anticipated result. So that would be my prerequisite to offer this to such a case. That's a no-brainer. And one point we have not discussed yet a lot is patient expectations. Yeah. So when we have such a case, we approach the patient with both options and answer his questions about anticipated, results and so forth. But then I like the patient to make the final, decision. And little surprisingly, very often that is for the less invasive transcatheter option.
True. Yeah, so thank you, Leonard. Maybe we can go back to the slide again, and that's the slide I showed you earlier. So indeed, there are a couple of aspects that you can take into it. It's a balance, yes, because this patient could indeed be treated either with TAVI or surgery, yes, let's be honest. So, okay, if we look to the new guidelines, first, he's 71. He's older than 70. He's 70 or older, so that favors in the new guidelines TAVI. Then if we look to anatomical features, well, there are no particular anatomical features which exclude them for surgery, neither for TAVI in this particular case. But there are, of course, other patients, and which are named there, which are interesting. So if there is some hostile annulus or LVOT calcification, of course, where you're scared more of annulus rupture or suboptimal result for PVL, yeah, clear. Then if this would be the case in this particular patient, 71, otherwise no other comorbidities, I would be happy to refer him to surgery, for example. Bicuspid aortic valve, well, that's discussable. In my center, I would say bicuspid. It depends from, as you mentioned, what kind of bicuspid. Yes, because bicuspid and bicuspid is not the same. They have extremely many different phases, bicuspid valves. So this patient could also, and if we think the bicuspid anatomy looks favorable for TAVI, I think he should definitely also be offered the option of TAVI. Annulus dimensions are not beyond risk of coronary obstruction, also nothing particular there. He's suitable for transfemoral, so that favors TAVI. If this would be now a patient with bad peripheral disease and you have to look for alternative access, I think it could still be offered, but that outweighing it against surgery, which is then maybe less stroke risk, I don't know. Porcelain aorta, intact coronary, that's patients with prior bypass grafts, or patients with prior chest radiation, for example, or chest deformity. That is about anatomical characteristics, yes, Thomas?
No, I completely agree. I think it's what is important in these patients is that it's not appropriate to only consider periprocedural complications, right? No. Even if we end up maybe with mild paravalvular regurgitation in a younger patient, mild paravalvular regurgitation may be irrelevant in a patient with a life expectancy of 1 or 2 years. Yeah. But not so in a patient with a life expectancy of 5 to 10 years. In those patients, even mild PVL can have an effect on mortality in the long term. I think this is important. It's not only about periprocedural risk.
You need a perfect result. In this type of patients, you need a perfect result. So
you want actually a perfect result, and you want to have this patient, if you think he has a life expectancy of more beyond maybe 8, 10 years, that you can have some revalving option. That's
exactly,
what you
yes, exactly.
Yeah. Okay,
I think that's
good.
important.
So maybe another question to Leonard. Leonard, you didn't mention anything to us about coronary angiography. Invasive coronary angiography. Did you do this in this patient? How was the workup? You showed clearly the echo. Did this patient have an invasive coronary angio?
As a matter of fact, he did not. I mean, on one hand, you could argue the age, the gender, the fact that he has been a former smoker, and the increased lipids could have driven us to doing that. On the other hand, we have adjusted a few years back already our diagnostic staging such that if you have a clear diagnosis from echo, then the next thing would be the CT, because we need it anyways, right? Yep. And if we can exclude coronary calcification here, then we would skip the angio altogether. And we've fared well with that up to now. But I'd be interesting to hear your stance on that.
No, very good. And I use it also as a small bridge to maybe the next topic, the next slide also. In the next 3 minutes, because we set in the learning objectives also that CT has been lifted up, yes, in the new guidelines. So if we can get the slide up maybe. So I think in what kind of aspects was CT got a more central role, yes, if we have patients with aortic stenosis? Well, first of all, in diagnostics. Not only diagnostics of coronary, but also diagnostic of if you have in doubt of your aortic stenosis severity. This was now a clear-cut case. He had a mean gradient of 40 millimeters mercury, but you have some discordant, low gradient cases where you really doubt there's suspicion. This patient looks like he had classical symptoms. He presents them with an aortic stenosis. You don't get the mean gradient out of above 40 on your echo. Well, it is now stated also in the guidelines that CT can help us in diagnosing actually and the severe aortic stenosis with AV calcium scoring. There are some cutoff values different for male and female. So that's one thing. Diagnostics also for coronary. That's just a question I asked to Leonard. Is this patient, does he still get an invasive coronary angio? Well, there is a Class 2A recommendation in the new guidelines, which says omission of invasive coronary angiography should be considered in TAVI patients if procedural planning cardiac CT is of a sufficient quality to rule out significant coronary heart disease. That's exactly what Lenard did in his hospital. And I have to say that's also what we do in 60% of our patients. They don't, and in Copenhagen, before TAVI, they actually don't have an invasive coronary angio anymore. The criteria are typically, the question is, did they have coronary heart disease before? Do they present with angina symptoms? If not, and if the CT shows no proximal suspicion of stenosis, typically we go ahead without invasive coronary angio. So you see CT is lifted up, has a more important role, can help in diagnostics, even it's not so much pronounced in the guidelines, but still even in the future, probably even more also for myocardial tissue characterization, fibrosis, etc. This maybe tells us more about the prognosis of this patient overall, but for sure, the CT has a very central role, as we mentioned before, in the discussion, TAVI or surgery. Yes, I think this should be almost a centerpiece. I mean, we have the clinical characteristics, but anatomical is almost on par, on the same level as important. And of course, if you go for TAVI, then even for the planning of your treatment is very important. Maybe Lenard can also confirm there that even for surgeons, having a CT can be super helpful in the planning, because if you have either a porcelain aorta or you have a very small annulus, you can maybe prepare for annulus enlargement, etc. And then last but not least, I think CT is also really important in these aortic stenosis patients for the follow-up sometimes, not routinely, but if there is an unexpected increase in gradient on echo relatively early, 1 or 2 or 3 years later, you have a mean gradient increase of 5 or 10 millimeters mercury, which you don't expect. Well, CT can be helpful to screen for leaflet thrombosis, leaflet thickening, maybe some early valve degeneration, and also it can be very helpful for planning future coronary and valve interventions. So this just as an intermezzo to say, well, look, CT has really been lifted up in the new guidelines. But now,
just one, is it the same attempt in your center? Because we do in more than, to be honest, 95% of all cases we are doing coronary angio. And I would say, to be an advocatus diaboli in this particular case, I saw some calcium in the left main. I would say, Lenard, you hear me?
I do.
Yeah.
Some calcium in the left main. Maybe, but it is a different type of attempt. Yeah. I think you are right doing this in that way, but we do in more than 95% of our cases, we do a coronary angio in advance.
Yeah, I mean, I think it's open for discussion, of course. We need some more robust data on that still. And even if you found a lesion, that's the next topic, I think. It's not the topic of today. That's another webinar, by the way, also on coronary, how to handle patients with coronary heart disease and aortic stenosis. So I'm not going to say too much. It's, again, another cliffhanger for another webinar. So going back to the case, Lenard, so now we've discussed your case. So what's your plan? What was your plan to treat this patient?
Yeah, okay, so we followed the 2/3 majority of the poll, which to me was also surprising, by the way. And this is just to quickly outline our interventional strategy, because the case obviously has been condensed down to a few minutes. We do most of our cases in local anesthesia, except for the occasional, urgent or unstable patient or someone who's not that compliant. We do still use transjugular pacing wire, because our cardianaesthetists have become so quick with that they will place the RV pace lead while we pass the valve ourselves. Transradial for the diagnostic pigtail. Pre-closure depends a little on who exactly in the team is doing the case. Most of us use ProStyle for pre-closure, and then angio-seal to complete the sealing. We do pre-dilate all cases that we use, that we indicate with the particular valve that we are going to use here. It's a large anatomy, so we're using a large balloon, 28 Trudel, and the valve that we chose was a Navitor Vision, so the latest iteration of the Abbott valve, and the largest also, 35 is what the labeled size is. So that will be our strategy, and I think we can just proceed to the case. Sorry. Before we do that, actually, for those of you who are maybe not that familiar with the valve, here it is. And I don't want to repeat all the things that we discussed already or I showed you from the CT, but let me assure you that in the red box, you will find that all the anatomical parameters are in line for this valve. A little on the large side, towards the upper margin, but still within range. And this is what the valve looks like. And now we can, I think, go to the case. I told you before that transradial access is our go-to strategy. This would be my first maneuver, then sonography guided or echo guided puncture of the access vessel. Pro style goes in, followed by a 10 French sheath, and then we confirm our angulation. This is what the valve looks like when loaded. The 35 valve size is going to be used, as I told you before. And then pigtail is in the non-coronary, and we cross the valve with an AL2 and a Terumo wire, which went nicely here in this low calcification anatomy. And then we follow with a pigtail, and then actually I skipped this, but what we do is an invasive gradient measurement here from the two pigtails, diagnostic one in the non-coronary and one in the apex, and then the Safari goes in for ballooning. 28 pre-dilatation, true dilatation balloon, as I said, in a brief phase of rapid pacing. So this is all absolute standard. The Navitor valve comes with an inline configuration that you may know from other self-expandable valve platforms. Very easy to use, I have to say. 14.5 French, I think what the manufacturer says, doesn't really matter, I think. Insertion orientation with the flush port away from the implanter to 3 p.m. or 3 o'clock to enable commissural alignment. You see those three roundish structures just above the stent inflow, will become a little more apparent a little later. These mark the commissures, and we like to start high with the stent inflow, the valve stent inflow lined up with the annulus more or less, or just 1 or 2 millimeters below. Because one thing that we have learned with the different generations of this valve platform is that we want high implant. And this is what we're doing here, intermittent, shots of contrast, if you like, to make sure you're still where you want to be. And you can see the commissural markers now a little clearer here. And with this first implant attempt, you can already see that we are way too low here. So the team is resheathing, because we stressed in the beginning, and this was exactly the discussion at our local heart team, what we do want is an optimal result. This is a way too low valve position, which we should not accept, I think, in these kinds of patients. Patient is completely stable. You can see the pressures on the left. This is also an advantage, I think, with intraannular self-expandable valves, as opposed to supraannular valves, which do regularly block blood flow, and this is absolutely not the case with this intraannular design. So we're resheathing or recapturing. It doesn't have to be a full recapture. We're still intraannular here, and now trying to seat the valve a little higher. This is the cusp overlap, by the way. So we're trying to aim at the left side of the screen. Mm-hmm. And there we go. So it looks nice, I think, on the non-coronary. By angio, valve seal is okay, I would say, for a semi-deployed valve. I do admit that it looks a little deep on the left coronary circumference. And we're discussing shortly here, but then decide to let the valve go because we have a nice high position to the left. And I think it's really important what we can see here, that you take your time. This is a delicate nitinol structure, less stent material than with other makes. So let the material work and expand in the bloodstream. And then here the valve is fully expanded. Make sure the delivery is detached from the 3 tabs that you see at the outflow. You can choose another C-arm angulation to really confirm this, relax the wire and come out. And this is the result. We do have important leak, which should not be accepted. I think we have nice commercial alignment from the position of the 3 dots here, of the 3 markers. And the team decides to post-dilate. I would have done the same thing. This is the same 28 true dilatation balloon. And I do think you can see that the valve expands further. And the balloon will go out in a minute. And I think we will be able to here show you the final angio, still a little on the low side, left coronary, but I think an excellent angiographic result for now.
Yeah.
And of course, we follow up these patients. Patient goes to the holding area, typically after these interventions, valve unit in the afternoon, and we try to discharge them somewhere within the first week, depending on how fast they recover. They do go to rehab in Germany mostly. This is the snapshot of the final echo with trace PVL and a 4 millimeter mean gradient. And I think that is all from my side for this case.
Yeah. Thank you, Lenard. Elegant case, nicely demonstrated. Just maybe a question, because maybe the audience, also, by the way, the audience, those who are following live, you can post questions, and we're happy to answer those. Maybe a question, because I know that many people ask that, your size of balloon, how do you do that? You use there a 28 millimeter balloon. What's the standard recommendation of size of your balloon when using Navitor, for example?
Yeah. I try to, for me, it's a millimeter below the mean diameter. Yeah, that's typically what I use.
That's exactly also what I do. I don't know, Alper, Thomas.
Yeah. Yes, pretty much the same. I think we were probably a bit more aggressive with pre-dilatation with the accurate neo valve, but with all the other valves, we go certainly below the area-derived or the perimeter-derived median.
But still, now yeah, that's true. But I would say many in the clinic out there, I think they go even with smaller balloons. There has been well, look, historically there has been in the early days, when really the early days of TAVI, I remember myself going almost always perimeter-derived mean, pre-dilate, and put a self-expanding valve in. There has been, just pre-COVID times, there was a tendency to go less and less with pre-dilation and even skip the pre-dilatation completely, or if you went for a pre-dilatation, to go matching more the minimum diameter of your annulus. Now, I think we had some learnings from, for example, Accurate with under expansion, Evolute with some infolds, also Navitor. If you don't pre-dilate well, you can also sometimes struggle with some expansion of the valve. So I think I totally agree with what Lenard said there earlier. If you work with, for sure, self-expanding technology, I think it's really mandatory almost to pre-dilate. And so that's one thing. And I think indeed, I also fully agree with the perimeter-derived mean minus 1 millimeter. That's also what I do. You also have to respect the perimeter-derived mean diameter. I mean, beyond that, you do never go. If you go bigger, you actually risk all kind of mechanical trauma or rupture. So that's the maximum. I think it's a plea also to go, if you go for a minimal diameter sized balloon, I would call this almost an suboptimal or ineffective pre-dilatation, I would say. So I think you did great there, and it's a good demonstration. Yes?
It's very important what you said. We need a proper pre-dilatation to achieve perfect results. And you have to know your valve, because not every self-expanding valve is acting like the others. So we are talking about two different types of valves. Someone has a good opening force and a good radial force. Others have a lower opening force with the same radial force. So therefore, you need a proper pre-dilatation to achieve perfect results.
Yes. And whether we have to do...
I agree completely. Just a brief comment, because isn't it true also that the intent of pre-dilatation has shifted away from, make a little room to bring in anything or bring in something to lesion preparation? At least that's what my cardiology partners have taught me, that term, lesion preparation. I think comes from coronary, right? But this is somehow a shift in intent for the pre-dil.
Absolutely agree. I think there's a tendency, and we know also that underexpanded valves are not a good thing to leave behind. First of all, underexpansion can lead to leaflet pinwheeling. It can maybe lead to more leaflet thrombosis, or maybe even more turbulent flow in the aorta, so maybe even more perivalvular thrombosis risk. So there's probably not a good thing to leave a valve underexpanded behind.
Yeah. We must not skip this point. We must not skip this point, because we have a 5 minutes or 4 minutes faster procedure, but at the end it's not a better procedure. So it's not about this 2, 3, or 4 minutes. Do a good, proper pre-dilatation.
And look, you also nicely showed your post-dil. I think it was totally justified in this patient. He was a young patient. If this would have been now an 87-year-old gentleman, maybe you could have said, yeah, fine, I mean, I'm done, we take it as it is. But I think here you wanted to go for perfection in your case, yes, in your index procedure, I think you did the right job. So maybe going further, we have a little bit of time still left. I want to ask you, Lenard, as a kind of a teaser, a bit fun question, like what do you think now, this patient, yes, he's 71, not a lot of comorbidities or no comorbidities almost, yes, no important comorbidities. You treated him well now. So what do you think he has of lifespan left? What is your estimation?
Well, you know, he has, we said earlier, he has no life-limiting severe comorbidities. He is 71. He has a nice valve in. He has no other cardiac conditions. So my gut feeling is he lives at least for another 10 years.
Okay. Well, look, I want to, if we can go to the slides, I want to share something which is, it's not unpublished data, but maybe if we can get the slides up, I don't know if you see them now. So what we did, we have in Denmark, I'm working in Denmark, and we have the luck in Denmark that we have fantastic databases in the Scandinavian countries. So what we did is, we have, over the last 15 years in Denmark, there have been treated almost 18,000 patients with aortic valve replacement, first time AVR. We defined 5 important chronic comorbidities: chronic heart failure, chronic lung disease, chronic kidney disease, diabetes, and peripheral artery disease. These are 5 dominant and often with a high prevalence that we see in our aortic stenosis patients appearing comorbidities. So on the right-hand side, you see a histogram of the prevalence. Of course, aortic stenosis is more frequent in patients with a higher age. That's not that interesting, that everybody knows. But you see also the distribution of how many patients have none of these 5 important chronic comorbidities, 1 or 2 or more. But the interesting thing comes here. So what we did is we wanted to know if you have, for example, a patient like Lenard, who is 71 years of age, he has none of these chronic comorbidities, he falls exactly here. So 71, no chronic comorbidities, probably he has about 11, 12 years of lifespan left. And look to the interquartile range. Of course, that means 50% of these patients fall in the range of 11 to 11.6 years left. So because our population is at large, we can relatively accurately, precisely predict how long this patient still has to live, which is quite amazing. So if you see also what also is important, because we brought up the topic of lifetime management, I think it's definitely applicable to the patient from Lenard. This patient has 11, 12 years left. So this patient is at risk of maybe coming back for revalving, yes? So, but if we're treating older patients, you see there above 80 or even above 75, it's almost none of these patients. Even if you have a 77-year-old patient, for example, with none of these important chronic comorbidities, only very, very few of these patients actually live longer than 10 years. Yes. So of course, if you go in the younger patients, clearly they live longer, but still most of the time these patients don't, these are not the patients that typically become 90 years. Yes, we overestimate sometimes the life expectancy of these patients. Anyway, so also, another couple of interesting data just to share with you, because it's very complete data. It's from a population in East Denmark, 3 million population, so 1% of the European population, Northwestern European population. So you see the prevalence of severe aortic stenosis. So now it's relevant in the discussion with the new guidelines. So for the former guidelines, patients above 75 years of age were already preferably treated by TAVI. That's the majority of patients. It's 54% of all our severe aortic stenosis patients are above 75 years of age. There is actually 20%, 19 to 20% of patients in that category between 70 to 75 years of age. So that's the population group that's now came into focus with the new guidelines, and only 27% of these patients are younger than 70 years of age. So coming back, I told you that they gave it a level of evidence A, for the new recommendation, TAVI in 70 years or older. It has sometimes been criticized by some. On the other hand, I think if you look to the low-risk randomized trials, the robust trials which are available there, such as Dedicate, Evolute Low Risk, Partner 3, Notion 2, well, the recruitment and the enrollment of these patients has been exactly in that age group. I depicted there the mean age and the standard deviation, so it's almost spot on in that group of 70 to 75. So I think indeed it justifies the level of evidence and the class of recommendation in the new guidelines. A small warning is maybe, though, that the more you go into the younger patients, these are also exact detailed patient level data from this Danish database, that you see that if you go more into the younger patients, you see more bicuspid anatomy, yes? So typically, a majority of patients above 75 or 80 years, it's 5 to 10% of your patients have a bicuspid anatomy. But if you go into the group of 70 to 75, that's 28%. If you go younger than 70, well, then it's half to 80% of your patients which have a bicuspid anatomy. And we have a lot, as Thomas said, we have a lot to learn of when is TAVI really indicated in bicuspid, yes or no. So what happens in real world practice? I want to share that still with you. I think this is slightly outdated data. You see it's from 2021. It's been published earlier in Eurointervention. This was to communicate how are patients now treated in Copenhagen or East Denmark with patients with severe aortic stenosis. So you see, in 2021, 4 or 5 years ago already, if you were more than 75 years of age, 90-95% chance you were going to be offered TAVI treatment indicated by the blue color, yes? On the other hand, if you look already, again, these are data from 4 or 5 years ago, in the age group between 70-75 years of age, it's almost a mirroring bar chart, yes? So it means we were already treating 50% of these patients with TAVI and 50% with surgery. Were we doing practice beyond or outside the guidelines? I don't think so, because you see on the box on the top, these are the reasons why we offer these patients TAVI. And you see there were typically good reasons for that. Prior cardiac surgery, that's a patient who had prior biprosthesis, aortic biprosthesis, or prior CABG with a lima. Typically our surgeons are not very enthusiastic to reopen the chest if there's a functioning lima, or severe lung, liver, renal disease, for example, an EGFR of 32, or a patient with moderately or severe COPD. These are also not, or liver cirrhosis, also not really surgical candidates. Morbid obesity, typically patients with a BMI of 35 or 40 and more. Severe LV dysfunction, reduced ejection fractions, 25, 30%, also not really the best surgical candidates necessarily. Active malignancy, that's typically we offer them TAVI in order to speed up their oncological treatments, or such a rare birth, such as prior chest radiation, that's a non-Hodgkin lymphoma patient. So I think all together seen, this is probably justified, yes. What we can expect with the new guidelines is, of course, you see there is a shift from 75 to 70. So what is already happening now today in our hospital is that you see these tricuspid patients in the lighter red color offered surgery still 4 or 5 years ago. Well, they are typically coming now to TAVI. That's around, for our practice, then around 50, 60 patients. And these bicuspid patients, well, we were already treating, as you see in the darker blue color, bicuspid patients with TAVI already 4 or 5 years ago in that age category, typically because these patients had some other comorbidities. But also now, from these surgical bicuspid patients, I would guess, I don't have the real data, but I guess 50% goes to TAVI, 50% goes to surgery. So it's kind of a split in these patients. But altogether, I would say, and that's also the kind of the cornerstone of this webinar, I think. I mean, heart team meeting has been put central, yes. All patients have to be discussed based on age, comorbidities, frailty assessment even, anatomy, which we really emphasized. And based on all these aspects, we have to make a real combined risk assessment, which hopefully is in the benefit of our patients, also considering lifetime management. So maybe, I don't know, Thomas, to finish off, how do you bring this in practice in your hospital, in Bern? You discuss indeed can we have a glimpse on how is that heart team process going? Is every patient discussed? Is there always CT present? How do these discussions go?
Yes, I think that's a very good question. So all the patients with aortic stenosis are being discussed in the heart team with a surgeon, with an interventional cardiologist, and with non-invasive cardiologists. And I think what is very important, as you alluded to, we don't only want to know about patient comorbidities that determines periprocedural risk, but at the same time, we also want to talk about anatomical risk. So we want to have CT for all of these patients, because I think without CT, if we don't see the anatomical risk, like the specificities, is there asymmetric calcification, what is the degree of calcification, where are the coronaries, how does the LVOT look like? I think if we don't have this, we don't have the full picture to really take an educated decision. And then I think the third point is not only about patient comorbidities and the anatomical risk, but then it's also about shared decision making. We also always talk about the decision that has to be taken between the surgeon and the interventional cardiologist. But there's also the patient. I think the patient needs to be aware of the potential benefits and the potential risks of the two different treatment modalities. And I think he can be a partner in this decision. I think that's important, to have the patient on board and explain or discuss with him or her exactly what are the benefits, what are the risks, what are the potential long-term implications of this decision or the other decision. I think that's important.
And then the decision of, if the decision has been taken for TAVI, you don't take the decision at the heart meeting, I guess, about what particular TAVI goes in or what is the best valve, first index valve, that you take within 2 years before the procedure, I guess.
Exactly. So we just take a decision, is this a surgical patient or is this an interventional patient for interventional cardiology or for transcatheter treatment? And then the decision about which device, what sizing of device, maybe also what strategy in terms of concomitant revascularization or stage revascularization, this we just discuss immediately before the case. But I think it's also something that needs, particularly in patients that do have relevant coronary artery disease, and we know about relevant coronary artery disease, this also needs to be brought to the heart team. But once we have taken the decision for a transcatheter strategy, like the detailed planning of this procedure, will be left to the interventionalist.
Maybe coupling back before saying goodbye to Lenard, maybe first thanks for sharing this very elegant case. You also heard the discussion here. You are the surgeon also here present. Do you have some final comments to us also still on this? And how do you look to these new updated guidelines?
So look, I think the gap in perspective from interventional cardiology and the new cardiovascular surgery is closing rapidly. I would sign off on most of actually everything you said. I think we try to move our specialty in the same way. We want something that we call a therapy agnostic diagnostic workup. How, as Thomas or one of you have said before, how can you determine your strategy if you don't have the diagnostics complete? It's impossible, and there's so many things you can learn from CT. We've tried to extend this to other valve diseases. The old-fashioned way was to do a lung function, to do an ultrasound of the carotids. All of this can be seen, and a coronary angio, most of this can be done by CT. So this is a real cornerstone, and this objectifies our decisions as well, right? It's not like someone has that gut feeling, someone has that gut feeling. We're a little more professional, I think, when we take this by heart and extend this to all our patients.
Yeah. Thank you, Lenard, and thank you for your contribution already.
So
and I think I want to...
Maybe
yes?
one more comment to Lenard, because we know each other very well. It's not about a competition between interventional cardiology and surgery. It's about a competition between two techniques we can use for valve treatment. And therefore, our decision should always be data-based. So evidence-based decisions. And the data are so good in terms of interventional cardiology or in terms of interventional valve therapy. So therefore, I think we are on a good way. And as Lenard also mentioned, there are key cornerstones to optimize therapy. And one of the cornerstones is imaging. Imaging in terms of CT, but also imaging in terms of echocardiography for diagnosis. And therefore, I think it is complementary to work together with brilliant cardiac surgeons like Lenard is, or with you both guys as interventional cardiologists. And I think it was, for me, a very, very fruitful discussion to be together with you in this room and with you, dear Lenard, from online, contributing to this discussion. I would like to say thank you to all the guys sitting in front of their displays and watching us. I think we had some really good points pointed out, like updates from the European guidelines. We highlighted the cardiac CT, the measurements, and the planning, the procedural planning. And I think it was very important to talk about the topic selecting the index valve and lifetime management. I think that we will have in the future webinars more detailed information in that topics as well. But I think it was a great time with you here in Paris. Thank you for being with me here, and thank you for connecting to us, dear Lenard. And I think that all the guys in front of their displays enjoyed the session like me.
Thank you for joining the webinar. Thank you.
Thanks.
Bye-bye.